everyone for being here today. The purpose of this discussion today is going to be mastering treatment of lumbar radiating pain. And, it's interesting, as I was thinking about this lecture and this talk, which I've done before, I've just revamped over the last few months, actually. I've considered changing the title a bit because when I think of, what I'm trying to do with these folks with radiating pain when they come to the clinic, I'm not trying to manage them, right? I'm trying to treat them. And the way I've thought and discriminated between management and treatment is management is, you're kicking the can down the road. You're managing them. They're moving down this, potentially endless road. Whereas treatment, right? Us as physical therapists, as the gatekeepers of the health system, we have the opportunity to get people better, right? Improve their symptoms, improve their function, get them away from the healthcare system so they can resume their lives, right? So again, you can see the strike through in management. It's mastering treatment of lumbar radiating pain. And do I really expect everyone to be a master after this? No, but at least provide some knowledge and some context around some of the really cool things we can do as PTs to make big changes in these individuals with lumbar radiating pain. So before we move on to the next slide, you guys can see my timer here for 1 minute. So I want you all to take 1 minute of time and gather a loose sheet of paper and a writing utensil. And then if you have your phone by you, you will need that as well to scan a QR code in the coming slides as well. So I'm going to start that timer. And please just take that minute to get those three things: a loose sheet of paper, a writing utensil, and then a cell phone or tablet that has QR code scanning capabilities. So interesting. I was like, do I set it for 30 seconds? Maybe I set it for a minute, and a minute seems too long now that I think about it. But we'll give everyone the full minute. All right. So winding down, go ahead and pause this timer and we'll click next. So again, on your piece of paper, you're going to think about these two questions. You're going to write the answers down to these two questions. And these are essentially going to be the essential questions that we consider throughout the entire duration of this talk, right? So on that piece of paper, spend 1 minute of time answering these two questions. To what degree can PTs impact those with radiating pain? Again, there's no right or wrong answer, just your beliefs. And then how do we intervene when multiple physical impairments are present in a condition? Okay, so 1 minute of time. Please take that 1 minute to answer those two questions. Awesome. So thank you for doing that. Finish wrapping that up. And what we'll do now is we'll go to this last question, at least for the time being. You're going to draw a 6 to 7 inch line on this piece of paper, with the left side of the line being numerically rated as 0 and the right side of the line being 10. And you're going to rate your confidence on that 0 to 10 scale in treating radiating leg pain currently. 0 being minimal confidence, 10 being maximum confidence. So we're not going to give you the full minute. We'll probably give you 15 seconds in the interest of time to do that. And then we'll move on the coming slides and content thereafter. So again, this is good for me, helpful for me to gauge, or helpful for you all to gauge an understanding of where you're at, and then we'll see how this is influenced in the coming slides. Okay, so as we move forward, right, it's important to level set some things. So Emily alluded to this. I went through an orthopedic residency program. I went through an orthopedic manual physical therapy fellowship thereafter. I completed that in 2022. And a lot of my training within those models was through the Maitland reasoning model, right? And some of these points are emphasized here, right? Hypothesis-based reasoning and pattern recognition. Hypothesis-based reasoning is your type 2 reasoning, right? You're slow thinking. You're thinking about what else could this be? What lives underneath here? What refers here, both in a somatic or a referral sense if we're thinking about lumbar spine pain or radiating pain. And then we also have to balance this thought process with our pattern recognition of this is our quick thinking. We're recognizing patterns on paper in a textbook, and we're quick to jump that this is my primary hypothesis, or this is a close competing hypothesis. There's constantly this battle or this tandem nature that comes with type 2 thinking and type 1 thinking. And that's how we become really efficient and effective with our handling of patients. Within the Maitland model, there's also this idea of the test, treat, retest model, right? So identify a few impairments that are relevant to the condition. I treat those impairments within the session. I then retest those impairments. And if those impairments are improved, right, there's a belief that the functional piece is improved, the pain is improved, the symptoms are improved, the quality of motion is improved, et cetera. So that is a hallmark within this Maitland model. And then I alluded to this already, but impairment tracking or asterisk tracking, those two words are synonymous. And then ideally we're finding asterisks or impairments that are relevant to the condition, right? Not just impairments that we all have. We all have some impairments to some degree, but which impairments are relevant to this individual with radiating lumbar spine pain, and how can we intervene to improve those impairments to improve their symptoms and function? And then without getting into too much detail, we're going to discuss SINS, right? SINS is a hallmark within the Maitland model. SINS is an acronym that stands for severity, irritability, nature, stage, and stability. Severity is essentially asking the question of how much is this condition impacting this individual's life, their sleep, their recreation, their work status. And we can rate this and identify this via, our Westry or different outcome measures that we have to identify percent disability, percent function. Irritability is essentially gauging how long it takes for the condition to get angry, and how long it takes for symptoms to calm down. So for instance, lower irritability is perhaps a condition where symptoms come about pretty immediately, but as soon as you cease the movement, the activity, the position, the symptoms go away. And higher irritability could be the opposite, where you bend forward, 3 times to pick up your child, and then you're incapacitated for 30 minutes, right? That's of higher irritability. Nature speaks to our pain mechanisms, right? Our mechanical or nociceptive pain, right? Think of this as the ankle sprain, where inversion hurts, plantar flexion hurts, but other things, dorsiflexion, eversion, are fine, right? Behaves very mechanically. Neuropathic pain, that's insult or injury to the nervous system, right? Resulting in some dermatomal or myotomal deficits, perhaps. And there's nociplastic pain, which is essentially associated with some central dominant mechanisms, where the mechanical pain that we once had with the ankle sprain is now hurting in all directions. It's very tender to palpation along all aspects of the foot, ankle. Inversion hurts, plantar flexion hurts, eversion hurts, dorsiflexion hurts, weight bearing hurts. It all hurts, right? So that's the final pain mechanism associated with that nature perspective. And then the second S is stage, so acute, chronic, and subacute, and stability is the last S, which is of some importance discussing progressive worsening, progressive improving of the condition, or symptoms staying the same, right? And the last piece within this reasoning model is that there's continuous reassessment, right? You identify an asterisk for impairment, you continue to improve the impairment over time, and that's going to dictate how you move forward with treating this individual in a condition. And another thing that's important to note that's been demonstrated in the literature for a period of time, right, is this understanding that pathoanatomy, right, these pathanatomic findings are very relevant in people without pain, right? And the healthcare system and society as a whole still believes these to be degenerative conditions, when in fact they're rather age-related conditions that begin on, MR imaging and X-rays beginning the third decade of life. And we've actually done a lot of research in the early 2000s comparing treating from a pathoanatomic approach to treating from an impairment-based approach. And impairment-based approaches are superior when it comes to comparing these two modes of treatment. And for those of you that may be familiar, there are many clinical classification systems that exist, such as the treatment-based classification system for low back pain, for neck pain. And we have many clinical practice guidelines for various conditions that help demonstrate which impairments are likely relevant. And if we treat those relevant impairments the appropriate way, the symptoms, the function all end up improving for our liking, right? So that's an important consideration as we move on into the meat of this lecture. And this is just an infographic, or excuse me, a screenshot from this publication by Berdrinki et al. Demonstrating those degenerative findings that the healthcare system has deemed degenerative are actually present, right? Even in asymptomatic patients, and you can see increase with decade of life spent on this planet, right? So we know, we can probably attest to some degree that we can't change, we can't directly influence imaging findings, but we can directly implicate the movement impairments through our movement assessments, through our movement examinations, through our movement interventions that can improve symptoms and function, and also likely influence indirectly the pathology that lives on the inside. Another important concept as we're getting into, again, approaching the meat of this lecture, which we're getting to, I promise, is this idea of centralization and peripheralization, right? We have to understand this in order to appropriately treat those radiating leg pain. Centralization, if we look at from that perspective, you're going to look at the body diagram on the right and shift over to the left, right? You'll notice the symptoms travel back up towards the spine where they came from and centralize towards the middle of the spine until they're eventually completely abated and there's no symptoms at all. Whereas peripheralization is the opposite. If you read this graphic from left to right, symptoms start in the central low back and perhaps they travel to the right, down the right glute, down the right leg, all the way down the leg. And that would be peripheralization. The literature is literature is never conclusive, but it is very promising and demonstrates that there are significant prognostic effects with centralization and significant deleterious effects if we do not centralize symptoms with peripheralized symptoms. And here is the famous story that is associated with Rob McKenzie and what initiated the McKenzie Institute, or the Mechanical Diagnosis and Therapy Institute. And I was so privileged in my fellowship journey. I had the opportunity to work with someone or receive mentorship and instructorship from someone who trained and worked alongside Rob McKenzie in New Zealand for a period of time. And she just took away so much knowledge and so much, was so grateful for her experience, and she shared a lot of that with us. And the story goes that Rob McKenzie is a famous physiotherapist outside of New Zealand. He's treating people with low back pain in his clinic, and he's running a little behind. And he tells this patient to lie on the table in the treatment room, and he'll be there momentarily. And then 50 minutes go by. Rob McKenzie steps in the room to treat this individual, and the individual hops off the table, exits the room saying, man, that was fantastic. I feel so much better. Thanks for doing this. And it's so interesting because if you and I, or maybe most of the people in the room, if we see this table, right, reclined in this fashion, we would probably sit on it with our back flush against it, with our legs pointed to the right of this image, or we would be sitting at the edge of the table with our feet dangling if a physician or a provider told us to, meet them at the table in the treatment room. But this individual laid like this on the table, and it completely centralized and restored their symptoms and their pain. And then Rob McKenzie was in a conundrum. He was like, how is this happening? And he dedicated his life to this research and how to centralize symptoms, and formed the McKenzie Institute, right? So what I do want to suggest before I move forward is I am not a MDT McKenzie trained therapist. Rather, I have many different outlooks within orthopedic physical therapy, and I've chosen things from many different camps, and I guess you can say I've created my own way of thinking about things, and that's what I'm going to share with you here today as we continue through or into the meat of this content. Lastly, this relates to the slide, the screenshot of the publication by Berginski et al., where we talk about all the degenerative pathologies that we see that increase as the decade of life continues on the planet, irrespective of pain or not pain or no pain. And what I want to highlight here is that, again, all these people with these impairments, mobility impairments, motor control impairments, radiating pain impairments, all of them have some of this living in their systems inside their skin, right? So it behooves us to consider, how can we intervene at the movement level? How can we intervene at the movement system to treat the movement impairments, to improve movement, function, pain, and as a result, maybe have an indirect effect on the inner tissue level, right? So again, a reminder that we do not directly impact things that live below the tissue surface, but can impact movement, which implicates things that live below the movement, or live below the tissue space. So when I think about my interventions for people with any type of pain, right, whether that's peripheral pain in the shoulder, in the hip, in the knee, in the spine, of course, which is what we're talking about today, I think of impairment buckets is one way to think about it, right? And I remember I came out of PT school. This was 8 years ago, and it wasn't even a thought in my mind that individuals would come to us had multiple impairments. Rather, they just had one impairment, and we had to change that impairment. And as a result, if we changed that impairment successfully, their symptoms, their function would get better. But come to find that individuals have multiple impairments, right? And we have to identify which impairment is most appropriate, which impairment is the greatest, and perhaps with our pattern recognition and understanding the condition, intervene there first prior to going and treating other impairments, right? So we're going to talk about these specific impairment buckets here, right? And again, you can see those little pink circles that are meant to be marbles, right? Marbles in the bucket, where, again, new professional me, right? I thought that you could only, the condition was associated with one impairment. And again, you change that impairment, you improve that impairment, the symptoms and the function is improved. Needless to say, over the last 3, maybe 4 years, I identified, holy cow, there's multiple impairments that are driving a condition, right? We have a good opportunity to find out which is driving the symptom bus, if you will, but we have to identify which are present to begin with, right? Because we can, if there are multiple impairments present and we don't address many of them or all of them, the individual might end up being 40% improved, 20% improved, 80% improved, but we can't get that final 20% because we're unaware of the other impairments to treat, right? So we are going to talk about these specific impairments within the context of those with radiating leg pain that's precipitated from the lumbar spine, how we can assess for these impairments, right? And then how we can make decisions on treating these impairments with the intention of making big change on day one or early on with these folks to help their prognosis and facilitate their exit from the healthcare system, at least from a musculoskeletal perspective. So here's a diagram. Follow along if you could, please. So we'll start at the left, which is traction. The folks that benefit from traction are the ones that have a positive straight leg raise and a positive cross straight leg raise, right? So the straight leg raise is super sensitive. It's 95% sensitivity, meaning that if you rule out, if they're negative on the straight leg raise, you can be highly certain that they don't have anything involving symptomatic discogenic pain, right? So if I lift up the involved side, aka the right leg, and it's less than 40 degrees, that is a positive straight leg raise. If I go and lift the left leg up, and it's less than 40 degrees, and they get their right-sided leg pain as I lift the left leg up, that is a positive cross straight leg raise, which is a very specific test, indicative of something happening at the side of the disc, right? More specifically, a disc herniation. And if those two tests are present, right, I can be highly inclined to perform some traction on this individual to do some nerve root unloading and allow for an environment for centralization process to start, right? So individuals that have those two measures present are going to be individuals that highly benefit from initial traction. It doesn't end there, but it begins there, okay? Now let's move over to our directional preference region. So directional preference can be broken up into repeated motions and those with a lateral shift. So to break down what a directional preference is, again, it's those individuals that have a preference to a certain direction of motion. And most people with radiating leg pain, they're going to have a preference to centralize. Remember, centralize is getting symptoms back to the spine, away from the distal extremity. They're going to respond well with repeated extension, and they're likely going to peripheralize with flexion, right? So there's a directional preference for extension versus flexion. And you'll find in certain textbooks, and you'll have a unicorn of a patient that comes to you and you think that they're going to benefit from some centralization maneuvers via extension. They do some extension, maybe times 5, times 8, times 10, and all of their symptoms are gone and they remain gone, which is incredible. I've only seen about 5 of those in real life, in the fact that the maneuvering actually allows for that. And they walk in my office angry and they leave happy and they never come back, right? That doesn't happen often, but it exists, right? So what happens there is the extension range of motion improves. As the extension range of motion continues to be elicited, that pumping effect that occurs from many mechanisms in the lumbar spine allows for some centralization of symptoms. And as a result, what we hope for is the centralization remains, right? We don't want to have it be where it sticks for 10 seconds or 10 minutes and it comes back. We want to have it stick entirely, right? So for those folks that fit in that category, they're wonderful. And you can give them a handshake and say, come back if you need me, but the hope is that they don't, right? The lateral shift, though, is a little bit more tricky, right? You can see a picture of a lateral shift there, which we'll get into more understanding of the coming slides. A lateral shift is essentially similar to our conversation before about directional preference. The individual may peripheralize with flexion, but upon attempting to extend to centralized symptoms, right, there's a barrier, there's a blockade, there's a stuck feeling that the individual feels where they might peripheralize when they try to extend, or they just can't because there's an inability to extend to create that environment to centralize. And we'll talk about some of the active range of motion differences you'll see in the coming slides, some of the passive range of motion differences you'll see in the coming slides. But note that what you'll see, what you might visualize, is a little bit of lateral shift, and we have to address that prior to addressing the environment centralized symptoms, okay? The mobility category is next, and we're going to speak specifically to the hypomobility subcategory of that, where there's limitations in motion of the spine. The spine is, for lack of a better word, stiff, right? And because the spine is stiff, it doesn't move well into extension. And we have to change that barrier, right? We have to create a runway, an opportunity, an environment for the spine to extend and centralize symptoms. Similarly, with the movement control category, we have an inability or a loss of motion with extension because the trunk muscles cannot help coordinate the motion into extension. So think about an individual, you ask them to extend, and what you're identifying is through some other assessments that they have some poor activation or motor control of their trunk muscles, their paraspinals, their abdominals. And then if you restore that motor control activation, you wake them up, they are then able to complete an extension motion to centralize symptoms, okay? So these are the 4 buckets that we're going to dive into a little bit further, and we're going to end up utilizing from a case as we near the end of this, or towards the end of this talk. Okay, so as we continue further on, right, the intention with our traction is that we initiate, supine traction is typically the most friendly. It can be in other positions, but we initiate some type of traction to allow for some centralization of symptoms or an environment where the individual can extend, create some extension motion and further centralize symptoms to improve function, pain, and abilities with the typical deficits that people have with radiating pain, which includes pain with walking, prolonged sitting, weight bearing, static standing, sleeping. Those are the typical symptoms that people have with, or typical deficits people have with lumbar spine radiating pain, okay? Similarly with the repeated motions, right? We want to do some repeated extensions if it sticks, right? Or the intention is it sticks, so that the individual can now restore those functional impairments and pain with sitting, standing, walking, sleeping, etc. Lateral shift, you restore the lateral shift via some side glides. You then restore extension because now extension range of motion is allowed to happen. You centralize symptoms and function improves, right? You're getting the gist here, I imagine. You improve now with the hypomobility, you improve lumbar hypomobility, you improve your accessory hypomobility of the lumbar spine, you improve extension, you improve centralization, you improve function. Trunk motor control, you improve activation motor control deficits of the trunk muscles, of the abdominals and or paraspinals, or even the lateral trunk wall with your obliques and such. You improve the opportunity for extension to occur, you improve the opportunity for centralization, and thus you improve function, okay? And this is getting a bit weedy, but bear with me, right? I had many opportunities to decide, am I gonna get this weedy or am I gonna stay superficial? And I decided to get weedy every time, so hang on. Now, this is a busy slide, I'm aware of that, but we're gonna go through each quadrant a little bit more specifically, and I'll reference the pictures accordingly. So individuals that may benefit from some initial traction, not traction forever. Traction is a mode to improve symptoms so we can get away from it, and they can do some more things actively or with our assistance. So traction benefits those who are of higher irritability. There's just the visual cues that they do not tolerate weight bearing. They are in moderate to high discomfort. They peripheralize with flexion extension. They might even peripheralize with the lateral shift correction attempt that you do if you see a lateral shift. The one thing that you have to do is you have to check their sterling grays and their cross sterling grays. If these are positive, right, traction is helpful. Initiate traction, centralize symptoms, give them some relief, and then create an environment where you can further centralize symptoms thereafter. Sometimes it's going to be multiple bouts, a couple of visits of traction. Sometimes it'll be one where you create the environment to move on, but give these folks some nice pleasantries of doing the extension or doing the traction, that is. So the lateral shift, you can see that image on the top right here. How we identify a lateral shift is indicative of where the trunk is in relation to a fixed pelvis, right? So you can see this individual, his trunk is shifted to the left in relation to his pelvis. We're going to name this a left lateral shift. Sometimes they're a little easier to see visually, sometimes they aren't, right? Some other cues that there may be a lateral shift present is if you look at the space in between the trunk and the inner arm, you can see more space on the left between the trunk and the inner arm than the right, indicative of there being a left lateral shift. You can also potentially see some skin folds increasing on the direction of the shift, right? We don't see that much present in this individual. Granted, there's a little bit of a shadow there prohibiting us from seeing that fully. Also, with our gait assessment, you can see increased arm sway on the left and decreased arm sway on the right by the nature of how close the arm is on the right to the trunk. It's just going to dissuade the individual to move their arms. So you might pick up on that via your gait assessment. And this is also commonly confused with a lateral shift, right? Or excuse me, the lateral shift is commonly confused with scoliosis, right? And the one of many ways you can differentiate between the two is that scoliosis, you're going to have that rib hump on one side when you flex, but then when you extend, you're going to extend and bias the other side. So the individual may flex and bias the right side. When they extend, they're going to bias the left side. In those with lateral shift, you're going to see them flex and extend remaining on that one side. So it's an easy way to, amongst others, to differentiate scoliosis versus lateral shifts. And both of these can be present too in the same condition, making it a little bit more difficult to tease that out and treat, but nonetheless, doable. So in those with a lateral shift, you'll have a limited extension motion. When you go to passively move the individual into extension, as you can see the screenshot on the left, you'll notice there's a little bit of a blockade, right? It's a stuck feeling. It's not limited per se, like it's limited by the nature of being stuck, and that's what you'll feel with this passive assessment. With your active range of motion assessment, you'll notice that they side bend more to the side that they're shifted on. So if we look at the individual on the top right, he would side bend theoretically more to the left than he would the right. If you look at the picture underneath that with the female therapist performing a lateral shift correction or lateral side glide, these would typically feel good and potentially help centralize symptoms and or create an environment where extension range of motion can be had to further centralized symptoms as well. So these are things that are indicative of a lateral shift being present. Let's now shift to the bottom right quadrant, or excuse me, bottom left quadrant from a mobility perspective. These are individuals that when you do the passive extension assessment, pictured on the left, you're going to notice that there's a limitation there. They just don't go further, they stop. And this may or may not be painful, right? It may be painful, it may not. And when you flip them and put them prone into your central and unilateral PAs to assess accessory mobility, these individuals will have some hypomobility that you perceive in their lumbar spine and or their thoracic spine as well. This is the demographic where you have the individual that's potentially an older male gentleman who is flexed forward at the waist a little bit. Those individuals are probably going to be perceived to have less extension. So we have to keep that in mind with our pattern recognition. If I see someone walk through my clinic doors with that presentation and with some radiating leg pain, I'm thinking that they might need to benefit from some restoration of spinal extension mobility. And the last quadrant is going to be the motor control category, right? These are the folks that when they flex forward, they have the aberrant motion or reversal of lumbopelvic rhythm. They stiffen up their spine to maintain an erect position instead of allowing the rounding of the spine, the natural lumbopelvic rhythm. They may demonstrate the Gower sign, where they're using their thighs to walk back up into a neutral standing position. Those are indicative of some trunk motor control deficits. Again, if we look at the picture on the left with the passive extension, these individuals might have an empty MCO or a spasm when you're attempting to move them into extension. And this likely happens because of the motor control and activation deficits of the trunk muscles. Because of the moderate or higher levels of irritability or severity, they have difficulty letting go and letting passive movement happen, and they want to help out. And as a result of helping out, they yield symptoms with this motion. And if you were to do some abdominal or paraspinal or other trunk assessments, you'd find out there's likely some impairments here in their ability to, activate these muscles, do some motor control exercises, etc. They would have a positive pitch test likely, which is the bottom picture on the right. And they may also be hypermobile, right, with your PA assessment, your central PAs or your unilateral PAs, where they have symptoms when you're approaching the end of motion, right? You're not getting symptoms at the end of the motion, but when you're approaching the motion. And this demographic here, again, it can be viewed a couple ways, right? One way is the younger adolescent female who's a little bit more lacks a little bit of muscle tone, right? So we need to improve their motor coordination, their motor control of the trunk muscles to improve their symptoms. This is the gymnast, the dancer, the cheerleader, and also there are other individuals that are adults, older adults that just are a little bit perhaps overweight, and they lack coordination and strength in their trunk muscles. And if we can improve those impairments, we can improve their radiating leg pain. Okay, so I know that was a lot, but bear with me. It's important as we get to our case later on. So again, as I say later on now, this is the initiation of our case. So individuals walk in with multiple impairments, right? There's multiple marbles in the impairment bucket where there's multiple pieces in the pie chart, right? It's not just a pie chart of one impairment driving a condition, it's multiple pies within the pie chart driving a condition. And here we have an individual with a visual lateral shift present, some perceived hypomobility, and some motor control deficits of their trunk muscles. These are perceived deficits that we're anticipating from the subjective exam with our hypothesis generation, as well as our objective exam, right? So I'm setting the stage for what we're anticipating, and we'll get into how we've anticipated and how we've come to those findings and how we're going to move on in the coming slides as well. So again, one thing is for certain, that's for sure, you can insert any condition here, but for the purposes of this talk surrounding radiating pain, no L5 radiating pain patient looks the same, right? You can see the pie chart there with motor control in blue, mobility in orange, and the lateral shift in green. They can all present with the same condition, the same thing on the referral from the physician, the same explanation of symptoms, but the way they physically move, their movement exam is different. And that's why we have to treat these patients differently. So can we, within our assessment, identify which of the major impairment buckets are present, how many of the impairments are going to be present within the pie chart that we're working with, and which one is driving the bus and which one potentially comes in second place. How can we do that? How can we discover that? And how can we utilize that data, extract the data from our assessment, and make decisions on how to treat this individual? So we're going to talk about that in the coming slides. Okay. So this is our objective data from the case. Let's go through it. I'm gonna be bear with me. I'm gonna go at it from an assessment perspective of standing, supine, prone. So I'm gonna bounce from box to box a little bit. So moving forward into the motor control category first. Let's say we observed standing flexion. We note the individual has aberrant motion. They stop flexing at about 40 degrees of flexion, and we notice they have a reversal of the lumbopelvic rhythm, right? They're keeping their trunk engaged, stiff, instead of rounding to decrease the amount of symptoms that they're feeling, okay? We now go to the lateral shift category. We have them do some extension motion. We perceive and we're visualizing that it's not a lot. This individual does not have a lot of extension motion. We visualize side bending. They're side bending to the left side further than they are the right. Think of the gentleman on the top right picture, right? There's a shift to the left. He can side bend to the left further than he can the right. We do what the female therapist is doing on the second picture on the right, the middle picture on the right, where we do a side glide. And we notice that, hey, it's limited, but there's also an empty end feel, right? When we think of empty end feel, I alluded to this earlier, perhaps there's involvement of the motor system, right? There's an inability of the motor system to let go. There's an inability of the trunk to help recruit and allow us to passively move the tissue. And now we have an empty end feel, symbolizing that there's no barrier that's felt, but there's something telling us that the individual is experiencing pain, okay? We now go into our supine assessment, where we assess the straight leg raise and cross straight leg raise. These are highlighted in red, indicating that they are both negative, right? So traction is probably off the table for this individual based on the data that we have and interpretation of this data. We go into supine and do our motor control assessment of the abdominals. Can this individual perform a posterior pelvic tilt? Can they do it consistently? Can they do it consistent with a good hold? Are they visually working so hard? Or can we identify that they appear relaxed, they're okay, and actually feels appropriate? Can we progress that to see if they can now do a supine hook line knee march, alternating in fashion, with engagement of the posterior pelvic tilt in their abdominals? Okay, great, they can do that now. Can they get up in this position where they're holding their knees up in a 90-90 position with a posterior pelvic tilt, with the abdominals engaged, and doing an alternating leg drop in a controlled fashion? If so, great. That means that they're likely demonstrating some consistent performance in their abdominals. If not, we need to intervene at this deficit. We identified in this hypothetical individual that the abdominals were impaired. We're then going to flip the individual over into prone, go to the mobility category, do our central and unilateral PAs, and we identify some hypomobility in the mid and lower lumbar spine. Okay, some hypomobility at, let's say, L3 through 5 with some CPAs and UPAs. Okay, and then we go off to the edge of the table. We do a PITS test. The prone instability test is pictured on the bottom right. The individual has pain when I'm on L4, sinking in there. I had them lift up their legs to engage the paraspinals, and holy cow, the pain reduces, indicating that when they wake up their motor system and engage it, the symptoms reduce, telling me that we need to work on some motor impairments of the paraspinals. So let's take a pause real quick and take a step back a little bit, if we will, and look at how there's multiple deficits and multiple impairments, right? I remember, if I was to reflect back at getting this data as a new grad, A, I wouldn't be able to interpret it, and B, I would be overwhelmed, right? The intention of this lecture is to provide some knowledge and content to decrease overwhelm and provide you with some considerations for next steps to help you move this individual along the continuum and treat them, not manage them, but treat them, okay? So we're going to revisit a slide similar to this, I believe next or shortly thereafter. And what do you know? It's next. So this is our patient X, right? This is our patient X. And if we can utilize the pie chart, we can utilize the marbles in the bucket metaphor, whichever suits you, they're both here. But traction, right? Individual is not benefiting from traction. They were negative. We redded that out for the striatal grays and cross striatal grays. There's a lateral shift present. There's increased distance between the left arm and the left side of the trunk versus the right. There's limited motion with extension. There's side bending further to the left side. There's an empty end feel with the side glide of the pelvis. So there's lateral shift stuff present. There's motor control stuff present, and it's you can't miss it, right? The individual flexes to 40 degrees. They get their symptoms. They have an empty end feel with passive extension. Again, indicative whenever you have an empty end feel or a spasm, something from motor control perspective or an activation or trunk performance thing is happening. And they have deficits. Now, let's say, excuse me, I said abdominals before, but they have deficits in the paraspinal region from motor perspective, and they have a positive PITS test. And we also have some hypomobility in the L3 through 5 region, CPAs and UPAs. So again, take a step back. Let's look at the pie chart. If that's your preferred visual, or you can look at the impairment buckets with the marbles. From the pie chart perspective, we have large motor control deficits with second place maybe tied for between mobility and a lateral shift. So if we're thinking to ourselves, where do we start, right? We can ask ourselves, where would we start based on this data? Where do we need to intervene to promote an opportunity for centralization to occur? I'll pause. I know that I'm not going to get some real-time feedback, but think about that. I have motor control deficits that are largest, some mobility, motor control, or excuse me, some mobility and lateral shift deficits that are second place, maybe tied for second place. Does this data provide me an opportunity to intervene in a, does it give me direction? Okay. And let's look at the green highlighted letters. The green highlighted letters here indicate centralization occurring. Centralization occurring, i.e. pain and function improving. The items not highlighted to the left of those arrows that are pointing to the right in the centralization are the variables that are involved, right? So let's say, let's look at the first example at the very top, A to B. That says one variable is involved. If we restore that variable, centralization occurs. So for instance, that variable could be repeated extension. Had them extend 8 times, holy cow, symptoms are centralized. I can now walk, sit, stand, sleep, I'm way better, okay? It could be the lateral shift is the biggest thing, is the only thing. I correct the lateral shift, they extend, their symptoms are centralized. Holy cow, what happens if there's multiple variables present? There's perhaps a lateral shift plus motor control, right? There's perhaps a lateral shift plus mobility, right? I have to figure out which ones are present, which one I treat first to promote an opportunity for centralization. Holy cow, there's 3 present, like in patient X. There's a motor control deficit, which we think is first place, lateral shift, and a mobility deficit. I have to do all these 3 things likely, address these 3 variables in order to promote an opportunity for centralization. Holy cow, there's 4 things, right? What are the 4 things that could possibly be present? I'll tell you, I've treated 5 variables before. And those could be, let's say there were 5 variables here, motor control deficits, mobility deficits, lateral shift, a concomitant scoliosis, which I guess is similar with what I was going to say with the other variable, thoracic hypomobility. So we have to address all 4 of those variables to some degree to influence an opportunity for centralization, okay? So what I want you to take away from this is you have the opportunity to centralize symptoms, but you have to be cognizant of which variables are present and how you can influence those variables, right? How you influence those variables may be dependent on how impaired the condition is. Maybe you have to start lower with an individual without any activation of their abdomen and paraspinals, and you can start a little bit more aggressive. Sorry about that, folks. But making sure that we understand what variables are present and how we can intervene with those specific variables to centralize symptoms. So let's say we're gonna treat this individual. Patient X comes to us with primary motor control deficits. I'm gonna do, because I identified a paraspinal deficit, so I'm gonna treat the paraspinals, and I'm gonna wake them up. Look at this therapist in here. take them out of the picture. They're not there. But think of the individual performing the PITS test as an exercise, where they bring their toes down here as the starting point, and then extend the legs up and repeat down and up, down and up. That is a paraspinal exercise, right? An easy to medium paraspinal exercise that can serve as a wake-up mechanism to the back muscles. So what I'm doing during this is I'm having my hands on the paraspinals, feeling if they're engaging, feeling if they're working, so to speak, seeing if the individual feels that they're working there. I'm looking for visual intensity. Is the individual working super hard, or is this easier, right? And of course, I'm engaging for symptoms. I think a lot of people, they are disinterested in assessing the motor system for fear that assessing the motor system will flare symptoms up, However, could it be true that because the motor control impairments are so prevalent that treating and assessing the motor system appropriately will actually reduce symptoms, right? Because that's where they're most impaired. That's my mindset. I'm going to treat the system. I'm going to assess the system in an easy to medium fashion, such as with this. And I'm going to reassess. Holy cow, test, treat, retest model present here. I'm going to reassess, and lumbar extension improves 10 degrees for a total of 25 degrees extension. Symptoms are centralized 50%. And now I notice that I don't have an empty end feel anymore. I have a limited end feel, right? So empty end feel spasms are associated with motor control deficits. I've essentially taken away a portion of the motor control deficits because there's no more of an empty end feel, right? So I've treated the motor system, I've reassessed, and that's made a 50% improvement in centralization and an improvement in extension, okay? I'm not done yet. Now I have to treat the other thing, right? I make a decision because they were tied for second place. Do I treat lateral glides, some lateral side glides to address lateral shift, or do I treat the hypermobility of the lumbar spine? Let's say I flip a coin, right? I assess it. I try to do some side glides, and I reassess for centralization and extension range motion. Nothing happens. So now I'm going to shift gears to address mobility deficits. So I do some L3 through 5 CPAs. Let's say I do some grade 3s for about 45 seconds, a minute, maybe per each segment. I retest, holy cow, lumbar extensions improved another 10 degrees for 35 degrees. I do repeated extension times 5 into that new range of motion now, and symptoms have centralized 90% at this point, right? I'm tracking symptoms where they are, where they're improving, the 0 to 10 pain rating, all of those things, and they've improved 90%. So I reassess my passive extension, right, because it tells me a lot about the end feel, tells me a lot about what's left on the table. I notice that there's still a limited end feel with passive extension. I'm now going to shift gears to my side glides, right, where I do some left side glides. Again, I want to get the pelvis underneath the side that the trunk is shifted to. So there's a left lateral shift. I want to do left side glides of the pelvis to shift them underneath the trunk that shifts to the left. I do this for about 45 seconds. I do some grade 4 mobilizations in this region. I reassess lumbar extension improves another 8 degrees for 43 degrees total. Symptoms are 100% centralized. I reassess passive extension, and holy cow, it's a firm, normal capsular end feel, meaning that I've attained full lumbar extension in this individual, but now I want them to keep it. I want them to keep this 100% centralization. I want them to feel great when they come in for their next visits. We can focus on continuing other things along the progressive ladder. If they don't, if something happens, that's totally okay, but to the best of my ability, I'm going to acknowledge next steps so that they can maintain symptoms moving in the right direction. So for my HEP, right, I have to consider the 3 buckets or the 3 portions of the pie chart that were involved fairly significantly. I'm going to treat the motor system via some paraspinal exercises. I have people typically do this at home on their bed. So they grab the footboard or at the edge of their bed with one hand, they grip their comforter with the other hand, and they lift up their legs at the edge of the table, right, at the edge of the bed, We then do some repeated extensions with addressing the centralization component as well as the mobility bucket to sustain that improvement in extension. And then I have them do some side glides at the wall, right? Teach them how to do the side glides themselves without me to maintain that, to get rid of that lateral shift and sustain improvements there. So you can see how all these things were addressed accordingly, but in a way that where the science meets the art of physical therapy, right? The science meets the art of physical therapy. And the science is identifying which impairments are the greatest, which impairments are present. And then the art is selecting how much of what vigor I want to do to address each impairment to make changes and allow for an opportunity for centralization. And I'm only as good as my home exercise program prescription. So I'm going to match what I did in clinic to similar vigor with some education of what things to look out for, what things to avoid, so that I can continue tracking symptoms and the patient can continue improving. Okay, this is an excellent case. Please, if you're here watching the recording, I would highly benefit you take some time and review this. So as a reminder again, right, L5 rating pain, I don't care if it's, for the purposes of this lecture, I do, yes, but no L5 rating pain, no L4 rating pain looks the same, right? It looks the same on the referral. It looks the same based on where they have symptoms, but it does not look the same based on the impairments that are present or the degree to which the impairments are in the deficit, right? So our exam, our ability to assess the lumbar spine accordingly and make appropriate and have an appropriate understanding of the data and where to move forward helps us understand how to treat, not manage these individuals with radiating pain. Now, I want to take a moment, right? Actually, 90 seconds or so. We're going to revisit these two questions. So on your piece of paper where you wrote down the answers to these two questions before, please take 90 seconds now to revisit those and write those answers on your sheet of paper. And as you're finishing up, if you're finishing up, think about what shifted your mindset around these two questions if there was a change. If there wasn't a change in your two questions, consider why there hasn't been a change. And if you're still writing, of course, finish writing and then consider reflecting on these two questions after we finish this call. Now, in the interest of time, we're going to shift to the next question. We're going to take 30 seconds here. That same 0 to 10 confidence rating that you had for yourself at the beginning of this lecture, I want you to rate yourself again. How confident are you in treating radiating leg pain? Five seconds or so. And as you're finishing writing those things down, if you shifted positively, why is that? Right? Consider the why behind that either now or as you reflect later. I know that this is similar to drinking out of a fire hose in this last hour, so perhaps you're feeling a little overwhelmed, which is totally normal, right? Totally normal and appropriate. You're questioning some of your current treatment paradigms. You're questioning how to move forward on with your rotations or in clinic the next day. Why is there potentially a shift in the opposite direction? Or perhaps your confidence is the same. Consider why you suggested that your confidence is the same. Excellent. And as we shift to the next coming slide, I want to revisit back to this idea of mastery, right? So I entitled my talk, right, Mastering Treatment of Lumbar Radiating Pain. And here's the funny thing, right? I am not a master of this, but I am in constant pursuit of mastery and mastering treatment of this clinically. And it would behoove you all who are interested in continued mastery or growing into becoming a masterful clinician to identify an organization, a culture where individuals surround yourselves, or where individuals around you surround themselves with learning. This learning never stops mentality, that will serve you very well as a clinician, as a new clinician, as someone who's looking to grow their practice. A culture of learning is the foundation for continued growth. These items listed 2, 3, and 4, right? If you have someone by your side that can serve as a mentor, that can help you clinically reason, not tell you what to think, right? Not tell you what to think, but how to think. I tell you how to think, provide opportunities for deliberate practice, deliberate feedback, and time, right? Plus teach you how, not teach you what, but teach you how to clinically reason and recognize certain patterns in certain cases, recognize what questions to ask to further your deductive reasoning. You will be much better for it. So surround yourself in an environment that bolsters a culture of learning and this mentality of learning never stops. And lastly, there is some onus on you, right? There is some onus on the individual. I can say that a large bit of my growth has been through honing in on honest practice and reflective practice. So taking time to reflect on cases. What's different about this case? What's similar with this case and this case? How did I mess up on this case? What did I do really well in this case that I could have done well with patient Y and not patient Z, right? And then being honest with yourself in clinical practice. When someone comes in and they say they're better, you better ask them to prove it to you, right? Their impairment should be better, right? Their things that you're tracking should be better. We don't settle for people coming in and saying they're better and just say, great, right? Prove it to us that you're better. Let me prove it to myself that you're getting better, right? By honing in and addressing and following the data, tracking the impairments, right? So all of those things are important. And if you're interested in pursuing mastery in something, right? It doesn't have to be clinical practice. It could be something completely separate in life, but surround yourselves with individuals that have like minds here. And I'm not going to play this video in the interest of time. However, when Matthew McConaughey won an Oscar in 2014, he gave a really profound, 3-minute speech, and a portion of that speech he addressed who he chases, right? Who's his hero, and his hero is him in 10 years, right? When he was 25, his hero was himself at 35. When he was 35, his hero was himself at 45. Identify for yourself who you chase, right? Who's your hero? If you're looking to pursue and become masterful in something, identify who that person is, because it will keep you alive in your life. It'll keep you alive in clinic, and it will create a fruitful career for you. So I'm super thankful and humbled to have the opportunity to give this to you all. As we wrap up, this is the final slide, I promise. Please take out your phones, your tablets, they have in front of you, and scan this QR code. There's a couple questions here. Again, it shouldn't take long, but I'm going to put the 5-minute timer going here. It's more of a way for me to track that what I was speaking to you on was understood to improve my own facilitation and instructorship, but also see what some of your takeaways were from this talk. So I'd really appreciate you spending no more than 5 minutes to fill this out. So I'm going to silence myself for 5 minutes as you complete those few questions. And as you're finishing up, maybe we won't go the remaining 3.5 minutes entirely, but as you're finishing up, know that my email is listed there. If you have any questions, comments, concerns, or want to dive into your own, goals as a future clinician, please do not hesitate to reach out. I love having conversations with people who are interested in pursuing their own development and their own growth.